Hello, everyone. We'll start our lecture today about testicular tumors, part 2. Previously, we speak about the type of testicular tumor, risk factors, and we speak in brief about each subtype of testicular tumors. Let us go to the second part of the lecture, is the staging of the tumor. A stage for germ cell tumors is according to TNM staging system. That's by American Journal Committee Classification 2017. We have this TNM is divided to T, which is tumor, primary tumor, according to clinical stage. Clinical stage is based on biopsy for PTS or based on imaging and or physical examination for CT4. So the biopsy for carcinoma in situ, tumor in situ, and imaging and examination for tumor grade 4, clinical stage grade 4. We have CTX, this is primary tumor cannot be assessed, and we have CT0, no evidence of primary tumor, and CTS, this is germ cell neoplasia in situ, and CT4 tumor invade the scrotum with or without vascular or lymphatic invasion. This is a tumor clinical staging. So T4 invades scrotum with or without vascular lymphatic invasion. We'll come to the primary tumor according to the pathological stage. As we mentioned, this is depend on T4, depend on imaging, but tumor is to depend on the biopsy. So the pathological stage is based on radical orchidectomy. You have BTX, primary tumor cannot be assessed. BT0, no evidence of primary tumor. And BT is or carcinoma in situ, germ cell neoplasia in situ, BT1 tumor limited to the testis, including grade to the testis invasions without lymphovascular invasion. That is carcinoma in situ or germ cell neoplasia in situ, no lymphovascular invasion. We have subclassification on BT1 applies only to pure seminoma. So the BT1 subclassification is only for pure seminoma. Pure seminoma, it's have subclassification T1A and T1B. T1A tumor is smaller than 3 centimeters in size. T1B tumor is 3 centimeters or larger in size. So T1A, T1B, this is only for pure seminoma. T1A, this is tumor is smaller than 3 centimeters in size. T1B, tumor 3 centimeters or larger in size. We have T2, that's tumor limited to the testis, including the rate of the testis invasion with lymphovascular invasion, unlike TIS or tumor in situ or germ cell neoplasia in situ. We have that limited to the testis with no lymphovascular invasion. Here we have BT2, we have lymphovascular invasion. Or tumor invading the higher soft tissue, or tumor invading the epidermis, or penetrating the visceral mesothelial layer covering the external surface of tunica albuginea with or without lymphovascular invasion. This is the BT2, and as you see here, this is a T1, and this is a T2, and we have T3 here. The T3 tumor directly invades spermatic cord, soft tissue, with or without lymphovascular invasion, and T4 tumor invades scrotum with or without lymphovascular invasion. We will come to the regional lymph nodes, clinical stage. In X, that lymph node cannot be assessed. In 0, no regional lymph nodes metastasis. In 1, metastasis with a lymph nodes mass is 2 centimeters or smaller in greater dimension, or none larger than 2 centimeters in greater dimension, multiple lymph nodes. This is N1. It is none larger than 2 centimeters in greater dimension, and multiple lymph nodes is considered as N1. And we have lymph nodes mass 2 centimeters or smaller in greater dimension. This is N1. N2, this is metastasis with lymph node mass larger than 2 centimeter, but not larger than 5 centimeter in grid dimension. Or multiple lymph nodes, any one of a mass larger than 2 centimeter, but not larger than 5 centimeter in greater dimensions is considered as N2. N3, metastasis with lymph nodes mass larger than 5 centimeter greater dimension. In greater dimension, the mass must be larger than 5 centimeters is considered as N3. And we come to the regional lymph nodes pathological state. We have NX, regional lymph node cannot be assessed, N0, the lymph nodes, no lymph nodes metastasis. N1, that's metastasis to lymph nodes 2 centimeter or smaller in greater dimensions, less than or equal 5, none larger than 2 centimeter in greater dimension. And we have N2, that's the mass lymph nodes. We have metastasis to lymph nodes larger than 2 centimeter, but not larger than 5 centimeter greater dimension, or more than 5 nodes positive, none larger than 5 centimeter, or evidence of extranodal extension of the tumor. N3, that's the lymph nodes greater than 5 centimeter in length. The distant metastasis M0, M0 no distant metastasis, M1 distant metastasis, M1A no retroperitoneal node or pulmonary metastasis, and M1P that's no pulmonary or visceral metastasis. Sorry, we have non-pulmonary visceral metastasis. Non-pulmonary visceral metastasis is considered as M1P, but no retroperitoneal nodal metastasis or pulmonary metastasis is considered as M1A. And this picture here, it show you the picture here show you that the classification accordingly. This is according to the TNM classification. Here we have the tumor staging from T1, T2, T3, T3AB, T4AB. This is tumor staging, and here we have the lymph nodes. The lymph nodes, we have N0, N1, N2, N3, and we have the distant metastasis, that's M1, M1, M1A, M1P. And this is the survival rate for 5-year survival rate for carcinoma in situ and T1. T1, it is 90%, T2 is 70%, and T3, this is T3A and T3B, it is 35 to 50%, 26 for T3A and 54 T3B. And we have T4A and T4B, the survival rate is 10 to 20%, 10 to 20%. Here we have serum tumor marker stage is determined using the nadir value of both orchidoctomy tumor marker in its upper limit of nodal for lactate dehydrogenase. We have serum marker 0, 1, 2, 3, and X. 0 normal and normal, all this 0. We have LDH normal, HCG, and alpha-fetoprotein all in normal. Serum tumor marker less than 1 times 5 times N and less than 5,000 HCG and alpha-fetoprotein more less than 1,000. This is considered as serum tumor marker stage 1. Stage 2, that's 1.5 to 10 times normal, or 5,000 to 50,000 HCG, or 1,000 to 10,000 alpha-fetoprotein per nanogram per ml. This is considered as S2. S3, that's more than 10 times N, or more than 50,000 or more than 10,000, more than 50,000 HCG, more than 10,000 alpha-fetoprotein, more than 10, this is LDH, it is considered as S3 or serum tumor marker stage 3. SX marker study not available or performed. So this is the S staging tumor marker for what we call it testicular carcinoma. In patient with testicular cancer, we use what we call it nadir value of post-orchidoctomy tumor marker. and this is known as upper limit of normal for LDH, and this is the upper limit for normal. All right, so it's 1 that's is less than 1.5, is 2 is 1.5 to 10, is 3 is more than 10, this is for LDH, is 1 for HCG less than 5,000, is 2 that's 50 to 5 to 50,000 milli MIU per mil, or more than 5,000 50,000, this is S3 or stage 3. For alpha fetoprotein, less than 1,000 to 10,000, more than 10,000, this is stage 1 to 3. All right. Let's continue. This is the staging group, stage 0. That's carcinoma in situ is considered as a stage 0. Stage 1, this is BT1 to BT4. And we have 1A, 1P. This is BT1, BT2. All is considered as 0. And we have 1B, T2, T3, T4, plus all 0, M0, M0, and S0 is considered as 1A, 1B stage 1. This staging group. Stage 1 is NTX N0 S1 to S3. This is considered stage 1S, stage 2, stage 3, stage 2A, stage 2, any no MITs, that's for all no MITs, and we have N1, it is with N2, 2, and we have staging. This is considered a staging system for staging group for testicular tumor. This is IGCCG risk categories for staging 2C and stage 3 germ cell tumors. We come to risk status, non-seminoma, seminoma. We have good risk, intermediate risk, and poor risk. So the good risk, all of the following for non-seminoma testicular retroperitoneal primary tumor, M0 or M1A, S0 or S1, this is considered as good risk. And we have for seminoma, any primary site tumor or M0, M1, or normal alpha fetoprotein is considered as good risk. So even M1A for seminoma is considered as good risk, or any primary site seminoma considered as good risk, M0, M1A, normal alpha fetoprotein considered as good risk. This is the risk status. This is for category 2C and 3, stage 3 germ cell tumor. When we come to intermediate risk, all of the following, testicular retroperitoneal primary tumor, M0 or M1A, S2, this is considered as intermediate risk. If we have testicular retroperitoneal primary tumor, M0, M1A, S2. All of the following for seminoma is considered any primary site, M1B, and normal alpha fetoprotein considered as intermediate risk for seminoma. And we have poor risk for non-seminoma, that's mediastinal primary tumor or M1P or S3, all this is considered as poor risk for non-seminoma. For seminoma, no patient are classified as poor risk for seminoma. No patient, we have intermediate risk that any primary site, M1B, or normal alpha fetoprotein. Good risk that any primary site, M0, M1A, and normal alpha fetoprotein. All this is considered for seminoma. But the non-seminoma, any of the following that include mediastinal primary tumor, M1B, S3, all this considered as poor risk. If we have MITs, if we have mediastinal primary tumor, if we have S3. CT scan of the abdomen and pelvis. CT cannot differentiate between cancer, teratoma, necrosis, and fibrosis. So CT cannot differentiate between this. Abdominal CT has 30% false negative, up to 30% men with the normal abdominal CT will have tumor in the retroperitoneal node. Therefore, CT accurately stage approximately 70% of the patient. So the accuracy of the CT is only 70%, which is good compared with ultrasound. So we have 30% false negative for CT and up to 30% men with normal abdominal CT have testicular tumor retroperitoneal nodes. For initial staging, CT of the abdomen and pelvis should be performed with oral and intravenous contrast if no contraindication exists. If abdominal CT show tumor, obtain a chest CT. Serum tumor marker. Tumor marker are measured before and after orchidectomy. However, S stage is determined using the nadir value. So S staging we will use nadir value post orchidectomy tumor. Beta, a human choriogonadotrophin, it is produced by sinusoidtrophoblasts. BHCG is always elevated with choriocarcinoma is present. We have elevation of BHCG can be caused by pregnancy, hypergonadotrophic hypogonadism, high level of LH can cross-react with some assay of HCG resulting in falsely high BHCG. Marijuana use for cancer, liver, biliary, pancreatic, gastric, and lung cancer. And also we have hyperthyroidism and heterotrophic antibodies, also antibodies that interfere with HCG assay. This is known as heterotrophic antibody. All this considered as cause of increasing the HCG. Here we have half-life for each one. We will come to HCG in days. It's 1 to 3 days. LDH in days, LDH1 in days, 4 to 4.5. And also alpha-fetoprotein is 5 to 7 days. Alpha-fetoprotein never elevated in pure choriocarcinoma or pure seminoma. So normally you will find that the alpha-protein level in choriocarcinoma and pure choriocarcinoma or pure seminoma. Elevation of alpha-fetoprotein can also occur within infants, liver dysfunction, hepatitis, cirrhosis, etc. Or cancer, liver cancer, biliary cancer, pancreatic, gastric, and lung cancer, all this relatively elevate level of alpha-fetoprotein. Infant less than 1 year old, it is normal for newborn to have elevated alpha-fetoprotein, which usually decline to the low adult level by 1 year of age. A portion of male population has alpha-fetoprotein up to 25 nanogram per ml in the absence of the abnormality. That means we have a portion of male population has alpha-fetoprotein up to 25 nanogram in the absence of abnormality. Normal alpha-fetoprotein less than 8. So it might find that alpha-fetoprotein 25. When alpha-fetoprotein above the normal cutoff, but less than 25, mainly and relatively stable, this finding usually not for testicular cancer. Other rare causes, ataxia, telangiectasia, hereditary trypanosoma, and hereditary persistence of alpha-fetoprotein and antibody interfere with alpha-fetoprotein assays known as heterophilic antibodies, as well as in the HCG interfere. It is considered for choriocarcinoma for high level of HCG, that's heterophilic antibody. Here also in alpha-fetoprotein we have this heterophilic antibody interfere with alpha-fetoprotein assay. All right, this is ataxia, telangiectasia, and hereditary trypanosoma. Hereditary tyrosinemia, and we have hereditary persistent alpha-fetoprotein level. With male proportion, with male population, portion of those population have alpha-fetoprotein level up to 25. And if we find that the level of alpha-fetoprotein is not more than 25, it is not considered as cancer according to this here. Lactate dehydrogenase. It's predominant lactate dehydrogenase isoenzyme in the testis cancer is LDH1, but the total LDH usually measured because the other isoenzymes are negligible. LDH may be elevated in seminoma or non-seminoma. So let us make this clear that in seminoma and non-seminoma, the LDH level increase. The magnitude of LDH elevation correlates with the volume of the cancer. Elevation of LDH can occur with many other conditions, including liver disease, heart disease, kidney disease, and other cancer, certain type of anemia, and infection, and also skeletal muscle injury. All this it will lead to elevation in level of LDH. Specifically, the what we call rhabdomyolysis, we will find that lactate dehydrogenase also increase. LDH is less specific marker for testicular tumor than BHCG and alpha-fetoprotein for non-seminoma. Therefore, treatment decisions should not be made based on a mild elevation of LDH less than 3 times the upper limit of normal. When the BHCG and alpha-fetoprotein are normal, we consider that the LDH is less specific marker. But if we find that the BHCG is very high and LDH is high, that might be non-seminoma. And also, if we find that the alpha-fetoprotein and also increase in the level of lactate dehydrogenase is also considered as non-seminoma, so therefore the management is clear. But if this normal and LDH is slightly increased, less than 3 times, this is not diagnostic for any testicular tumor. We will come to the gonadal stromal tumors. We have what we call it granulosa cell tumors. The granulosa cell tumor is rare, benign tumor that usually occur in the neonatal period. 75% are diagnosed with 1 month of birth. Orchidectomy for the granulosa cell tumor is curative. It's curative for them. So granulosa cell tumor is rare benign tumor and usually occur in neonatal period. 75% are diagnosed with 1 month of birth. If you come to sertoli cell tumor, 10% of sertoli cell tumor are malignant. The only reliable indicator of malignancy is the presence of metastasis. So sertoli cell tumor might secrete estrogen or testosterone. Sertoli, it secretes both of this hormone, estrogen or testosterone. The presentation is painless testicular mass. Viralization or gynecomastia occur in sertoli cell tumor. Treatment non-metastatic sertoli cell tumor are treated with orchidectomy followed by surveillance. So we treat it by these methods. Leading cell tumors, 10% of the leading cell tumor are malignant. The only reliable indicator of malignancy is the presence of metastasis. So histology is eosinophilic cells. Histology, you will find eosinophilic cells. Extra ringis crystal is called cigar-shaped or lobular-shaped red crystal. This is in leading cell. It's called crystalloid rings crystal. The crystalloid rings crystals or cigar-shaped or lobular-shaped red crystals. Leading cell may produce testosterone and 17-ketosteroid. This leading cell produces these two important testosterone and 17-ketosteroid. The presentation children usually present with precocious puberty, viralizing features such as pubic hair and masculine voice and prominent external genitalia. All these come with leading cell tumor in children. The children usually present with precocious puberty, viralizing features such as pubic hair, masculine voice, and also prominent external genitalia. Adults often present with impotence, low libido, and feminizing features such as gynecomastia. Klinefelter syndrome and adrenal cancer, congenital adrenal hyperplasia may cause similar symptoms. All this, it will lead to similar symptom of leading cell tumor. Okay, so Klinefelter's and adrenal cancer and congenital hyperplasia lead to similar feature of leading cell tumor. treatment non-metastatic leading cell tumor are treated by orchidectomy followed by surveillance. The persistence of viralizing or feminizing features after orchidectomy is not necessarily an indication of residual tumor because this change can be irreversible. So, presence of this viralizing or feminizing feature after orchidectomy is not necessarily an indication of residual tumor because this change can be irreversible. Metastatic tumor are often resistant to chemotherapy and radiation. Metastatic tumors are often resistant to chemotherapy and radiation. So metastatic tumors are often resistant to chemotherapy and radiation. Germ cell neoplasia in situ, previously used name for germ cell neoplasia in situ include intratubular germ cell neoplasia and carcinoma in situ. So the germ cell neoplasia, or known as GCNIS, this previously used for germ cell neoplasia include intratubular germ cell neoplasia and carcinoma in situ. So germ cell neoplasia is non-invasive precursor of germ cell cancer. I mean, it's pre-malignant. The germ cell neoplasia is considered as a non-invasive precursor of germ cell cancer, and it is pre-malignant. The risk factor for germ cell neoplasia include history of germ cell cancer, gonadal or extragonadal, atrophic testis less than 12 centimeter, and cryptorchidism, intersex, infertility, and age less than 40 years old. All this is considered as germ cell neoplasia in situ risk factors. History of germ cell cancer, including gonadal or extragonadal, and also we have atrophic testis less than 12 centimeters, and we have cryptorchidism, and we have intersex, infertility, and age less than 40 years old. When testicular germ cell tumor is present, the surrounding parenchyma of the ipsilateral testis contain germ cell neoplasia in situ in over 80% of the cases, and parenchyma of the contralateral testicle contain germ cell neoplasia in 5% of the cases. So testicular germ cell neoplasia is present. The surrounding parenchyma of the ipsilateral testis contain germ cell neoplasia in over 80% of the cases, and parenchyma of the contralateral testis contain germ cell neoplasia in 5% of the cases. In men with multiple risk factor, example, male with testicular cancer or testis cancer, and atrophy of contralateral testicle, this is considered as multiple risk factors. The germ cell neoplasia, risk of the germ cell neoplasia in contralateral testis increased to at least 33%. So by these risk factors, male with testicular cancer or atrophy of the contralateral have a risk of 33% for contralateral testicular cancer. For patients with testicular germ cell cancer, some clinicians advocate for biopsy of contralateral testis if undescended or markedly atrophied testis, because these tests have a high risk of having germ cell neoplasia in situ. So the patient with testicular germ cell neoplasia cancer, some clinicians advocate for biopsy. For what testis? For contralateral testis. If it is undescended or if atrophied, it is better to do for them biopsy. When germ cell neoplasia is untreated, approximately 50% of the men will develop germ cell cancer in involved testis with 5 years old, so 5 years duration. So germ cell neoplasia is untreated, and approximately 50% of the men will develop germ cell cancer in the involved testis within 5 years. Germ cell neoplasia does not elevate serum tumor marker. Testicular biopsy is the only way to diagnose germ cell neoplasia. Testicular biopsy is done through the inguinal exploration. The approach should not be transscrotal. So it is better to do biopsy by transinguinal for germ cell neoplasia to diagnose, because the risk of the cancer, if 5 years, if we don't do biopsy within 5 years, the 50% of the men develop germ cell cancer. 2 separate testis sites should be biopsy. So the biopsy through 2 inguinal incisions separately, 2 testis sites should be biopsy, and 3 cubic millimeters of tissue is removed at each site and preserved in Bowden solution. So we preserve it in Bowden solution, not formalin. It is better to save them until we do histology for them. In adult male with germ cell testis tumor, biopsy of contralateral testicle at the time of orchidectomy may be offered when the risk of germ cell neoplasia is high. Multiple risk factors for germ cell are present. In prepubertal male with germ cell tumor, biopsy of the contralateral testis is unnecessary because children really have germ cell neoplasia inside. So in this period, prepubertal male with germ cell tumors, biopsy of contralateral testis is unnecessary because children rarely have this. History of cryptorchidism is a risk factor for germ cell neoplasia in adults. However, testis biopsy at the time of prepubertal orchidectomy is not recommended because the natural history of germ cell in children is not well characterized. We'll come to treatment of germ cell neoplasia. Controversy exists regarding whether it is necessary to diagnose and treat germ cell neoplasia. It is unclear if treating germ cell neoplasia improves survival compared to treating the germ cell cancer if it is developed. So since cure rate of germ cell cancer is high, some experts advocate not diagnose or treating germ cell unless it turns into germ cell cancer. Management option for germ cell neoplasia includes surveillance, radical inguinal orchidectomy, testis radiation, or systemic chemotherapy. All this is as management options for germ cell neoplasia in situ. Treatment with radiation, chemotherapy, or orchidectomy can cause hypogonadism and infertility. Therefore, you must counsel the patient. Radiation is less likely to cause hypogonadism than orchidectomy, but post-treatment eliminates sperm production from the treated testicle. So therefore, sperm banking for reproductive age is advised. Orchidectomy or radiation will cure almost all cases of germ cell neoplasia in situ, but chemotherapy cure only 60% of the cases. If patient wish to preserve fertility and or testosterone production, then surveillance is the best option for germ cell neoplasia. If neither fertility nor testosterone production are concerned, then orchidectomy is the preferred because cure rate is 100% like radiation. Radiation is an option, but it impairs fertility and 50% develop hypogonadism. For this reason, we prefer option of orchidectomy to not expose the patient to the radiation. As well, we have hypogonadism with orchidectomy, but it's better to do orchidectomy rather than exposure for radiation. In most cases, chemotherapy is not recommended for treatment of germ cell neoplasia because of its inferior cure rate, which is, as I mentioned, it is 80%. If you, it is chemotherapy cure rate is 66%. Sorry, 66% for patient with germ cell neoplasia. Surveillance in men with solitary testicle or men with who wish to preserve fertility and/or testicular testosterone production, surveillance is usually recommended because other treatment can cause infertility and hypogonadism. Follow-up is performed on regular schedule and include scrotal ultrasound, physical examination by doctor, and physical exam by the patient self-testis exam. Orchidectomy achieves 100% cure in the treated testicle, but has the highest risk of hypogonadism among the management options. So the high risk for germ cell neoplasia orchidectomy is high risk for gonadism in patients with orchidectomy compared with radiation and chemotherapy for patients with same problem. External beam radiation to the testicle achieve more than 97% cure in the treated testicle, but 50% of the patient will require testosterone replacement for post-radiation hypogonadism. The treatment dose for external beam radiation is 18 to 20 GY. Chemotherapy eradication, as we mentioned, for eradicate germ cell neoplasia is in approximately 66% of the cases. In most cases, chemotherapy is not recommended for treating germ cell neoplasia because of its systemic side effect and its lower cure rate. However, it is an excellent option for men who will already be undergoing chemotherapy for germ cell cancer. Since the cure rate is only 66% after chemotherapy, post-chemotherapy biopsy of the testis can be performed to confirm the resolution of germ cell neoplasia. However, the biopsy should be performed for more than 2 years after chemotherapy. We'll come to the type of seminoma. We have classical type or typical type seminoma is known as classical or typical seminoma. This is 95% of seminoma. Growth pathology for this type of seminoma is lobulated, growth pathology lobulated and pale color. Histology show large uniform cell with clear cytoplasm and distinct cell border. So the histology, we have large uniform cell with clear cytoplasm and distinct cell border. Distinct cell border, this is the histology of the seminoma. Large uniform cells, clear cytoplasm, and distinct cell border. The nucleus might have two nuclei. So the nucleus have two nuclei or single eccentric nucleus, which make the nucleus look like what we call it fried egg, like this fried egg. Might be, as I mentioned, single eccentric nuclei or two lobulated nuclei. As we see here in this picture, this is what we call it single eccentric nuclei. And here we have this distinct cell border. As we mentioned, we have two nuclei. This is a nucleus, have two nuclei or single eccentric nucleus, which is make nucleus look like fried eggs. Here, this is fried eggs. This is fried egg nucleus. This is a fried egg nucleus. This is the two nuclei here. As you see here, we have these two nuclei. Here, this is the two nuclei. It's fried egg. The cytoplasmic is clear. As we mentioned, the cytoplasm is a clear cytoplasm. As you see here, clear cytoplasm. And this is the nucleus. And we have inside the two nuclei. Cytoplasm is clear. We have nucleus, and inside we have two nuclei, as you see here, or one eccentric nucleus. It looks like fried egg. This is a classical or typical seminoma. Okay. We have also, as I mentioned, distinct border. Sinocytotrophoblasts, which produce HCG, are present in 10% of the case. That's why 10% of seminoma produce BHCG. So sinusoidal which produce BHCG, present in 10% of the case of the typical or classical seminoma. And also we have lymphocytic infiltration is present in 20%. As general rule, we mentioned that the testicular cancer is spread by lymphatics. We have exception for leading cell and choriocarcinoma, which is run through the hematological spread. But here we have 20% of seminoma, it is lymphatic infiltrate. Anaplastic seminoma, this term is of historical interest and no longer used. It referred to classical seminoma with high mitotic activity. It became evident that mitotic activity did not impact prognosis. Therefore, the designations was not useful and it is abundant, but it is considered as high mitotic activity. That's why it's called anaplastic. Spermatocytic seminoma. This is 5% of seminoma. So we have typical seminoma or classical seminoma is 95%, and we have spermatocytic seminoma is 5% of seminoma. Histology cell of varying size that resemble maturing spermatogenia. Most spermatocytic seminoma are pure, so the most of it is pure, but the histology cell varying size that resemble to maturing spermatogenia. Spermatogenia, it looks like the typical cell for spermatocytic seminoma. It is 5% of seminoma. Most spermatocytic seminoma are pure. They are not mixed with other germ cell cancer. Cryptorchidis does not increase risk of spermatocytic seminoma. It does not occur more frequently in the undescended testes. Spermatocytic seminoma present at an older age, more than 50 years old. This is a spermatocytic seminoma. Compared with seminoma, which occur between 30 to 40 years. 30 to 40 years, we will find seminoma at this age group. So spermatocytic seminoma present at an older age than typical seminoma. Usually presenting age more than 50 years versus 30 to 40 years respectively for seminoma. Spermatocytic seminoma rarely metastasize. Spermatocytic seminoma is usually treated with radical inguinal orchidectomy surveillance because of its low metastatic potential. We have this kind of information on seminoma. Diagnosis of pure seminoma require normal alpha-fetoprotein and orchidectomy histology, demonstrating only seminoma, non-seminoma elements. No non-seminoma elements, sorry. Demonstrating this histopath orchidectomy histology, demonstrating only seminoma. Seminoma is most common germ cell tumor. It is 65% of the germ cell tumor. So the seminoma is 65% of the germ cell tumor. It's the most common germ cell tumor. 65% germ cell tumor. Age of presentation, we mentioned that 30 to 40. Present and older than classical. So this is a presentation of spermatocytic seminoma in older, which is more than 50, and this is 30 to 40 respectively. At the presentation, most of pure seminoma are confined to the testis, not metastatic. Metastatic usually occur in the retroperitoneal lymph nodes. Pure seminoma never secrete alpha-fetoprotein, but it secrete BHCG in 10%. This is a pure seminoma. That's why we mentioned that the BHCG positive in 10% of the cases. Seminoma is radiosensitive, chemosensitive. If histology show only seminoma but alpha-fetoprotein elevated, then the patient is assumed to have unidentified non-seminoma that is treated as mixed germ cell tumor. So non-seminoma is a mixed germ cell tumor. Mixed germ cell tumor are, we will speak about the non-seminoma. First, we have mixed germ cell tumor, that's seminoma and seminoma, mixture of seminoma and seminoma. Mixture of germ cell are treated using the protocol for non-seminoma. Embryonic carcinoma. the usual presenting age is 25 to 35 years old. Growth pathology, a gray-white flashy mass with poor defined capsule. Necrosis and hemorrhage are often present. Histology, epithelial-like cells that form papillary projection. Tumor marker may secrete alpha-fetoprotein and or BHCG. This is a this is an embryonic carcinoma. Embryonic carcinoma occur between 25 to 35 years old, and the gross pathology here is gray-white fleshy mass with a poorly defined capsule. And also, necrosis and hemorrhage are often occur in embryonal carcinoma. The patient with embryonic carcinoma have necrosis and hemorrhage. Histology, epithelial-like cells that form papillary projection. Histology, epithelial-like cells that form papillary projection. Tumor marker in embryonic carcinoma, that's alpha-fetoprotein and or BHCG is positive. That's why the tumor secretes this alpha-fetoprotein. Of the non-seminoma tumors, embryonic carcinoma is the most undifferentiated tumor. So if we ask about the most undifferentiated tumor, the answer will be that is embryonic carcinoma. Embryonic carcinoma is a non-seminoma with an undifferentiated tumor, the most undifferentiated. It has capability to differentiate into any of other type of non-seminoma. Yolk sac tumor, usually presenting age is children less than 10 years old. And the most present at the age is less than 2. So that's the age is less than 2. The gross pathology a yellowish or pale gray mass. Compare with the embryonic carcinoma, which is pathology is gray-white, fleshy mass. Here we have yolk sac, it's yellow, pale, gray mass. Yellow, pale, gray mass. This is in less than 2 years, yolk sac. But usually present in children less than 10 years old, but the most present at the age of less than 2. The growth is usually yellow, pale, gray mass. Histology epithelial cell-like cell that forms cystic space is known as Schiller-Duval bodies. Schiller-Duval bodies or embryoid bodies or hyaline globules might be seen. All this is seen in your sac. We have Schiller-Duval bodies or Duval bodies. We have embryoid bodies and we have hyaline globules. These 3 histological or 4 histological cystic space, Schiller-Duval bodies, embryoid bodies, and hyaline globules. All this is present. Tumor marker secrete both as well as embryonic carcinoma secrete alpha-fetoprotein and or BHCG. Metastasis hematogenously, especially to the chest. Usually yolk sac metastasized to the chest. Welcome to the choriocarcinoma, usually presenting age is 20 to 30 years old. Gross pathology is gray-white. Compare with yolk sac, which is yellow pale gray mass. And we have also embryonal, which is gray-white flashy mass. We have yolk sac is yellow pale gray mass. And we have choriocarcinoma, which is gray-white mass. Tend to peripheral in the testis. Usually choriocarcinoma is in the peripherals of the testis and often has central region of hemorrhage. Histology, sinusoidal multiple nuclei, eosinophilic cytoplasmic secrete BHCG, and cytotrophoblastic signals nucleus, clear cytoplasmic nucleus. So the histology of sinusoidal multiple nuclei, and also we have eosinophilic cytoplasm, and we have this secrete HCG, and cytotrophoblast single nucleus clear cytoplasm. The choriocarcinoma is also the choriocarcinoma Choriocarcinoma is never secrete alpha-fetoprotein and always secretes BHCG. Choriocarcinoma early hematogenous spread, especially to the lung, as well as what we speak about it previously. Here, yolk sac metastasize hematogeneously are usually to the chest, as well as choriocarcinoma is usually metastasized hematogeneously and to the lung. They may be small. So they may be small primary testicular tumor, but large volume of the metastasis. So you might find small primary testicular tumor, but the patient might have large volume metastasis. Choriocarcinoma has worse prognosis of all testis tumor. Choriocarcinoma have worse prognosis of all testicular tumors. Teratoma, usually presenting age is 25 to 35 years old. We have the same tumor present at this age, what we call it embryonal carcinoma. Embryonal carcinoma is 25 to 35 as well as teratoma. Teratoma is 25 to 35 as embryonal carcinoma. So teratoma is often cystic. The cyst lining stain positive for carcinoembryonic antigen. So teratoma is cystic lining stain positive for carcinoembryonic antigen, and gross appearance depends on the type of tissue that's present. Teratoma histology in multiple germ cell layer in different stage of the maturation. We have endoderm, we have mesoderm, we have ectoderm. The endoderm, that gastrointestinal respiratory tissue, mesoderm, that's bone cartilage muscle, ectoderm, that is squamous epithelium and neural tissue. Teratoma is sometimes classified as having mature or immature element. But this classification is unknown significant and does not alert the malignant. The teratoma tumor marker, teratoma may secrete alpha-fetoprotein. This is one important tumor marker, is known as a tumor secreting alpha-fetoprotein. Teratoma is resistant to chemotherapy and resistant to radiation, therefore it requires surgical resection by inguinal approach or chydectomy. Also, teratoma usually grow slowly, so the growth of this tumor is slow. Sometimes teratoma demonstrates rapid growth that encases and or invade nearby structure is known as teratoma growth syndrome. Teratoma growth syndrome, this is a demonstrate rapid growth in cases or invade nearby structure. But usually the teratoma grow slowly. Rarely teratoma can be differentiated into somatic, is known as non-germ cell malignancy, such as sarcoma or adenocarcinoma. This condition is called teratoma with somatic type malignancy. The previously used term is teratoma with malignant transformation. This is no longer recommended. The name of teratoma with malignant transformation is no longer recommended, and teratoma with somatic type malignancy, this is non-germ cell tumors. Malignancy such as sarcoma or adenocarcinoma is known as somatic, and this condition called teratoma with somatic type. This picture here shows us periurethral type teratoma in a patient with age of 60 years. As you see here, we have distinct form post-periurethral teratoma, and periurethral teratoma are not associated with germ cell neoplasia in situ, lack of cytoplasmic atypia, do not show chromosome 12p amplification, not associated with gonadal dysgenesis, microschisis, and also parenchymal scarring. And this is the management for this is orchidectomy. This is periurethral teratoma usually behave in a benign fashion. It does not metastasize or degenerate into a somatic malignancy. Also, both periurethral teratoma appear histologically benign. It has potential to behave in malignant fashion. It can be differentiated into somatic malignancy, and it can grow and invade local structure. As you see here, it is very clear this is the prepubertal teratoma. Another dimension in this point here, it is look yellowish white keratinized material. That's a concentric or lamellar arrangement. Concentric and lamellar arrangement, this is the description here. We have this tumor yolk sac, a usual age group less than 10, and marker alpha-fetoprotein and BHCG may be in both, as well as embryonal. We have also embryonal yolk sac, maybe, and maybe have high level of alpha-fetoprotein and BHCG, and also the age is less than 10 years. Embryonal as well as teratoma with the same age group, 25 to 35, and also embryonal might have, as well as teratoma, have high alpha-fetoprotein. But remember that the teratoma never secrete BHCG, as well as the teratoma never secrete BHCG, as well as choriocarcinoma, which is never secrete alpha-fetoprotein, and seminoma is also never secrete alpha-fetoprotein. BHCG might be secreted in all tumor except seminoma. All testicular tumors secrete BHCG, except teratoma never secrete BHCG. But the high level for choriocarcinoma that usually secrete BHCG. Okay, so alpha-fetoprotein yolk sac is resistant to radiation and it's sensitive to chemotherapy, this yolk sac. And the pathology finding is known as Schiller-Duvall bodies, embryonal body, hyaline globules, globules. This is in yolk sac. Choriocarcinoma, this is 20 to 30%, is cytotrophoblast, central hemorrhage. All this is 20 to 30, and it is never alpha-fetoprotein, and BHCG is usually or always resistant to radiation and sensitive to chemotherapy. As you see here, all the tumor is sensitive to chemotherapy. All this is sensitive to chemotherapy, but all of it is resistant to radiotherapy, except typical seminoma is sensitive for both radiotherapy and chemotherapy. Okay, I hope this is clear point for you. And when we come to the choriocarcinoma, as I mentioned, we have cytotrophoblast, and central hemorrhage. And when we come to the embryo, we have papillary projection. We come to teratoma, we have multiple germ cell layers, often cystics. And when we come to seminoma, typical seminoma, we have clear cytoplasm, stem cell border, and we have fried eggs nucleus. This is all about the summary of this. Here, this is the Schiller-Duvall bodies. As you see, it's Schiller-Duvall bodies with vascularity or blood vessels inside. This is pathognomonic for yolk sac tumor, also called endodermal sinus tumor, a germ cell tumor typically seen in gonads or testis or ovary. We have colic sensor bodies. This is characteristic of granulosa cell tumors of the ovarian testis, granulosa cell tumors. You will find this, what we call it, colic sensor bodies. And this is for teratoma. As you see here, we have ectoderm. This is known as neural cell. And we have mesoderm, which is known chondrocyte for cartilage and for muscle and for bone. And we have intestinal epithelial endoderm. This is for adenocarcinoma. So it is what we call it teratoma. Gonadoblastoma is rare benign tumor that occurs almost exclusively in patients with gonadal dysgenesis from an intersex disorder. Also, gonadoblastoma is benign. 60% undergo transformation into malignant germ cell tumors. Thus, bilateral gonadectomy is recommended. So, gonadoblastoma usually present during and after puberty. Phenotype, female with virilization in this groups, and also male with hypospadias and cryptorchidism is considered risk factor for gonadoblastoma. And as I mentioned here again, gonadoblastoma is benign. 60% undergo transformation into malignant germ cell tumor. So therefore, we recommend for them bilateral gonadectomy. A phenotypic female with a virilization, or male with hypospadias, or male with cryptorchidism is risk factor for developing gonadoblastoma. Treatment of testicular cancer. Before treatment, obtain tumor marker, liver function test, CBC, and creatinine. Counsel the patient, but regarding potential effect of surgical excision of the mass, including infertility and hypogonadism, and also discuss with option of placing testicular prosthesis. In patients of reproductive age, offer for them spare banking prior to the cancer treatment. Ideally, the patient should preserve sperm before orchidectomy. So surgical excision of the testis mass, avoid transscrotal biopsy and transscrotal surgery. This is the first point. Second point, in adults at high risk of germ cell neoplasia in situ, multiple risk factor present, consider biopsy of contralateral testicles during the tumor excision. In prepubertal male, biopsy of contralateral is unnecessary because the children rarely have germ cell neoplasia in situ. Radical inguinal orchidectomy when malignancy is suspected. Radical inguinal orchidectomy is preferred treatment for men with normal contralateral testicles. Through an inguinal incision, the testis and surrounding tunica vaginalis are excised in block with epislateral spermatic cord up to the internal inguinal ring. Up to the internal inguinal ring, we will remove the testis by inguinal incision up to the level of internal inguinal ring. This is the rule. As you see here, we try to do radical orchidectomy plus or minus prosthesis for the testis. We will stop at the level of internal inguinal ring, as I mentioned here. Internal inguinal ring, this is our landmark. The testis sparing excisions, the rationale of the testis sparing is preserve as much gonadal function as possible. Preserve fertility and testosterone production. So this is known as testis sparing excision. The rationale for testis sparing is to preserve the much gonadal function to avoid hypogonadism and infertility. In adult, testis sparing is often done only when the serum testosterone is adequate and preservation of fertility is desired. The testis may as well be removed if fertility is irrelevant and hypogonadism is already present. As I mentioned, at the level of this point, a deep inguinal ring or internal ring, we will remove the testis and we will do for the patient procedure. The testis masses thus are non-palpable and less than 2 centimeters are benign in the least 50% of the case. AUA guideline states that the testis sparing surgery should be offered to patients with testis mass less than 2 centimeters, where the AUA 2021 guideline did not specify size cutoff, stating that the mass should be suitable for inoculation. So they mentioned that no specific size cutoff. So the less than 2 centimeters is mentioned by AUA, and no size cutoff for testicular mass for surgery by AUA 2021 guideline. Testis sparing is reasonable when the patient wishes to preserve gonadal function or fertility. Any of the following conditions are present. So if the patient tumor is a patient tumor solitary testicles, and also the tumor in solitary testicles, contralateral testicles poorly function, and it contribute. That means contralateral testis is poorly functions it contributes minimally to fertility and or testosterone production. Synchronous bilateral testicular tumor that is likely benign when the tumor marker are normal and tumor less than 2 centimeters in greater dimension. This is offered for the patient testis sparing surgery. Testis sparing surgery has high local recurrence rate than radical orchidectomy, 11% to 0% for radical orchidectomy. So testis sparing surgery have 11% recurrence, high local recurrence, compared with radical orchidectomy 0%. The risk of local recurrence is higher for seminoma. Local recurrence is higher for seminoma than non-seminoma. The risk of local recurrence higher for seminoma compared with non-seminoma. Option for adjuvant treatment to reduce local recurrence include radiation to the ipsilateral testicles for seminoma or chemotherapy for seminoma or non-seminoma. So we have option of radiation for seminoma, for ipsilateral seminoma, or chemotherapy for seminoma or non-seminoma. Before testis sparing surgery, counsels the patient about the risk of the infertility and hypogonadism, require testosterone replacement in 7%, epistatic testis atrophy 3%, intraoperative radical orchidectomy, local recurrence, and need for adjuvant therapy to reduce local recurrence. This is before testis sparing surgery, counsels the patient about the risk of this. First, infertility. Second, hypogonadism, require testosterone replacement in 7%. In epistatic testis atrophy in 3%. Intraoperative radical orchidectomy, local recurrence, need for adjuvant therapy to reduce local recurrence. For testis sparing surgery, mobilize the testis and spermatic cord through the inguinal incision, occlude the spermatic cord and excise the mass. Further section determine if the mass is benign and if the surgical margin are negative. If it take a long time to obtain results for frozen section, then cool the testis to reduce ischemia. For prolonged spermatic cord occlusion, if entire mass cannot be exclusive, the testis sparing mass cannot be excised with testis sparing, then perform radical orchidectomy. In adults with germ cells, obtain multiple biopsy of the normal epistatic testis tissue to check for germ cell neoplasia in situ. The surrounding ipsilateral testis parenchyma contain germ cell is in over 80% of the case. The presence of germ cell neoplasia increases risk of local recurrence of germ cell cancer. After excision of the germ cell testis cancer, obtain post orchidectomy serum tumor marker, monitor tumor marker until nadir value are reached. Post operatively, it usually take more than 5 half-life to eliminate excessive circulating marker. 5 half-life is 1 to 2 weeks before for HCG. T half-life 1 to 3 days. And that's HCG. It's 1 to 3 days. 3 weeks for LDH. And that's the half-life, which is 4 to 4.5 days. And 5 weeks for alpha-fetoprotein. The half-life is 5 to 7 days, as we mentioned previously. So this is 5 half-life. Is important. Usually take more than 5 half-life to eliminate excessive circulating marker. We will wait more than 5 half-life. More than 5 half-life, so more than 3, it is up to 2 weeks for BHCG, and more than 20 days or 3 weeks for LDH, and more than 5 weeks for alpha-fetoprotein, so more than 5 half-life. Again, it is very important point obtain post-orchidectomy serum tumor marker. When to do that, for more than 5 half-life to eliminate excessive circulating level of tumor marker. The tumor marker for BHCG, it is 1 to 3 days half-life, and also for what we call it LDH is 4.5 days, and also for alpha-fetoprotein is 5 to 7 days. It's up to 5 weeks. So we'll wait until the tumor marker reduce. This reach to up to 5 weeks. S stage is determined using the Nadir value for post-orchidectomy marker. Small post-orchidectomy elevate of tumor marker might not be caused by testis cancer, especially in patients with no visible metastatic disease. Evaluate these patients for alert etiology of marker elevation and monitor the marker level. Patients with microscopic or undiscovered metastatic disease typically have a consistent rise in the tumor marker, where the patients with non-malignant source of the marker elevation usually have relatively stable marker level. Imaging for staging. For cross-sectional imaging, CT with IV contrast is preferred, but MRI with gadolinium might be used if iodinated contrast is contraindication. So we will use MRI with gadolinium if the iodinated contrast is contraindications with CT, so therefore it is preferred to use MRI with gadolinium. Abdominal and pelvis cross-sectional imaging performed on all patients with testicular cancer preferred by CT with IV contrast. If the patient have allergy to the iodinated material, we will use MRI with gadolinium. Chest imaging for clinical stage 1A or 1B pure seminoma. If the patient have 1A or 1B, we will use chest imaging for clinical. Normal tumor marker and normal CT abdominal pelvis. Chest X-ray preferred over the chest CT. If the chest X-ray is abnormal, then obtain chest CT with IV contrast. So chest X-ray is preferred in patients with seminoma. Chest CT with IV contrast is preferred in all other patients, including patients with non-seminoma, abnormal chest X-ray, metastasis on physical examination, or on abdomen and pelvic CT, mean stage 2 and 3, or an elevated post-orchidectomy tumor marker, including 1S stage 1S. This is indication for CT, indication for CT chest with contrast. If the patient is seminoma and we do for him chest X-ray, which is abnormal chest X-ray in patient with seminoma, we can do. It is better to do CT chest with IV contrast. If the patient with non-seminoma and have abnormal chest X-ray, also we'll do for him the CT with contrast. If the patient have metastasis on physical examination or metastasis on abdomen and pelvic CT stage 2 and stage 3, or if the patient have elevated tumor marker post-orchidectomy, including stage 1S. Brain MRI with or without contrast should be done when any of the following criteria are present. Neurological sign or symptom are present. BHCG more than 5,000. Alpha-fetoprotein more than 10,000. Extensive lung metastasis. Non-pulmonary visceral metastasis. This is indication for brain MRI. You can do brain MRI for neurological sign or symptom are present, BHCG, alpha-fetoprotein more than 10,000, and extensive lung metastasis, non-pulmonary visceral metastasis. Bone scan can be performed when clinically indicated in patients with post-orchidectomy serum tumor marker, but imaging is inclusive for metastasis, then consider repeat imaging 4 to 8 weeks This additional imaging might clarify the extent of the disease before management is finalized. When we repeat the image post-orchidectomy, if serum tumor marker, if the patient have normal serum tumor marker post-orchidectomy, and the image inclusive for metastasis, we repeat it 4 to 8 weeks. In patient with pure seminoma, in orchidectomy specimen, there are two findings on post-orchidectomy tumor markers that suggest the patient also have non-seminoma. In patient with pure seminoma, in orchidectomy specimen, there are two findings on post-orchidectomy tumor marker that suggest the patient has also has non-seminoma. BHCG elevation over 1,000, BHCG South International Units, BHCG elevation per liter elevation over 1,000 international is rare with pure seminoma. Elevations alpha-fetoprotein, elevated alpha-fetoprotein can occur for two main reasons, as I mentioned. We mentioned that the elevation of alpha-fetoprotein can occur for two main reasons. Alpha-fetoprotein is not from the testicular cancer. Evaluate the patients for the cause of alpha-fetoprotein elevation. Alpha-fetoprotein source is from non-seminoma testis cancer. Review the orchidectomy specimens to see non-seminoma and might be missed on the initial evaluation. Also conduct through the evaluation for metastatic disease. Assign TNM stage and group for patients with stage 2C or 3 cancer. Assign an IGCCG risk category. The AUA guideline recommended that the treatment decision based on the imaging that was performed within the previous 4 weeks and tumor marker performed within the previous 10 days. Evaluation and treatment of the adult and evaluation of treatment of the children, we will see it later. After excision of non-germ cell testis cancer, the testis lymphoma treated with systemic therapy. Lymphoma is considered systemic disease even if it is present only in the testis. For treatment of gonadal stromal tumor, leading cell tumor, sertoli cell tumor, and granulosa cell tumor, this is after excision of non-germ cell tumor. For patients with stage 1 and stage 2 non-seminoma germ cell cancer whose orchidectomy specimen contains teratoma with somatic type malignancy, then the preferred treatment is a full template bilateral retroperitoneal lymph node dissection. These tumors are typically resistant to chemotherapy and radiation. Scrotal violation in testicular malignancy. Scrotal violation occur within BT4. Tumor invades the scrotum, trans-scrotal orchidectomy, trans-scrotal biopsy. Scrotal violation can alert the normal lymphatic drainage from the testis, which mean lymphatic spread from the testis cancer can go to the superficial inguinal lymph nodes. Previous inguinal surgery may also alert lymphatic drainage from the testicle, allowing the cancer to spread to the ipsilateral inguinal and iliac lymph nodes. Transscrotal biopsy, transultrasound, and transscrotal orchidectomy. If there is a suspicion of the testicular cancer, transscrotal biopsy, transscrotal orchidectomy are avoided because increased risk of the local recurrence compared to the radical orchidectomy through the inguinal regions, and they can alert the lymphatic drainage so that the cancer can spread to the inguinal lymph nodes. The Also, in transscrotal biopsy, transscrotal orchidectomy increase the risk of the local recurrence. They do not allow systemic relapse or overall survival. Local recurrence occur in 2.5% in the men with scrotal violation compared with 0% in the men without scrotal violation. Among men who underwent excisional of scrotal scar after scrotal violation, only 9.3% had residual tumor in the resected specimen. Treatment, the optimal treatment is unclear, but consider the following. If stage T4 suspected at the time of the orchidectomy, then orchidectomy should be probably being done with block excisions of involved portion of the scrotum. After transscrotal biopsy, perform a radical inguinal orchidectomy. Consider in-block excisions, the biopsy tract, and the scrotal scar. After transscrotal orchidectomy, AUA 2019 guidelines state that the adjunctive therapy or adjuvant therapy may rarely be considered for local control because only 2.5% of the patients have local recurrence. Adjunctive treatment options include excision of the scrotal scar, radiation of epislateral hemiscrotum for seminoma only. For patients with seminoma and scrotal violation who will undergo radiation, the field can be modified to include the epislateral iliac and inguinal lymph nodes and epislateral hemiscrotum. This is for patients with seminoma and scrotal violation who will undergo radiation. The field can be modified to include epislateral iliac and inguinal lymph nodes plus epislateral hemiscrotum. Follow-up include inguinal lymph nodes palpation in the physical examination and include inguinal and pelvic lymph node on imaging. This is the end of this part. We will meet again in testicular tumor part 3. Thank you very much.